Hi, my name's Ewan Griffiths. I'm a consultant upper GI surgeon from Birmingham in the UK, and this is the talk I gave to the 21st ISDE World Congress in Brisbane this year on esophageal and esophagogastric junctional adenocarcinoma patient selection and optimization. I have no commercial relationships or disclosures. I like this quote from Blake Cady um, suggesting that biology is king, but selection of cases is the queen, and the technical details of the operation, whether they're robotic, open, minimal access, or whatever, um, whilst they are powerful forces, they don't usually overthrow the biology as king. Um, and but today I want to talk about selection, which is clearly the queen of getting good results. My talk outline is I'm going to talk about patient selection for surgery, oncology, who shouldn't be operated on, is the patient fit for resectional surgery, a bit about comprehensive geriatric assessment, frailty, age, and sarcopenia, and then talk a bit about what we can do to maybe optimize patients for surgery to get borderline patients over the line. What we all want is the sweet spot. We want an experienced surgeon in an experienced unit operating on patients with really good fitness, with excellent oncological curability. And if we get all this, we'll get excellent results. But unfortunately, it's not a perfect world out there. And this Venn diagram shows that any particular way where one bit falls over, we get potential risk to outcomes. It's probably easier to start with who shouldn't be operated on. Oncologically, um, in my eyes, T4 disease, the tracheobronchial tree, large vessels, and spine is not an indication for surgery. Neither is multivisceral metastatic disease. Out of field nodes in the supraclavicular or cervical nodes or non-regional nodes in the retroperitoneum means patients are inoperable and should be treated palliatively. In terms of comorbidities, it's difficult to put a fine line on this, but patients with child B, C cirrhosis, really poor lung function, or severe chronic renal disease, or performance status 3 and 4, definitely shouldn't have resectional surgery either. But of course, there's a grey zone. There's a grey zone between definite no's and definite yeses, and this is where we have things like cytologically positive disease, resectable oligometastatic disease, patients with fairly minor comorbidities such as child's A cirrhosis, moderate COPD, frailty, or borderline performance status or fitness. And this is where the surgeon and unit experience comes in, and it really just depends on the appetite for risk and what previous outcomes have had that the unit or surgeons had on these sort of borderline patients. And the experienced surgeon eyeball test probably isn't good enough anymore to decide who should be for surgery, and we should probably be much more objective in our patient's assessment for this. But sadly, risk stratification protocols fail us. This is a study that really showed that standard risk prediction models very much overestimate the risk of complications. Surgeons underestimate risk, and individual surgeons estimate risk differently. Can we use age? Well, as we know, age is just a number, but there is good evidence, and this is a meta-analysis I was involved in, that age um, of this meta-analysis of over 30,000 patients, that higher ages led to increase in overall complications, pulmonary complications, cardiac complications, and reduced levels of 5-year survival and 5-year recurrence-free survival, but no difference in anastomotic leak. But we all know that age is just a number, and we probably need to do better than just an age grouping. And that's why it's really good to get your geriatricians or preoperative assessment team to look at frailty and comprehensive geriatric review. And it's really important to do this in patients who are elderly or frail at risk of sarcopenia. A CGA is effectively a multidimensional assessment. It normally takes between 30 to 45 minutes and can be undertaken either by a geriatrician, a specialist nurse, or a preoperative assessment team. And it involves different aspects, including mental state evaluation, formal documentation of their performance status, a review of their medication and treatment of polypharmacy, assessment of their mood and depression, assessment of their functional status using the activities of daily living or the Duke activity score, also a formal frailty assessment, an assessment of their comorbidities. And this is a really interesting graph shown in a review by Clegg et al. In the Lancet, looking at functional status over time in patients who have minor or major illnesses. And as you can see, in a devastating illness, they can cross over the threshold from being independent to being dependent on care. And we see this in our esophagectomy cohorts. If the patient's highly active and does well, they can recover from a minor complication. But if they're borderline, you can convert a patient who was independent and coping at home to somebody that has to go to a nursing home for ongoing care. Sarcopenia has many definitions. It started off just with a loss of muscle mass with age, and then people added strength, loss of strength, and now it has particular sort of mass muscle measurements on CT scanning, and is much more accurate. And I don't want to over egg this, but it is an important issue. And it can be caused by a variety of things, including physical inactivity, malnutrition and cachexia, other malabsorptive or endocrine conditions, inflammatory disease, or metabolic syndrome and insulin resistance and obesity. As well as assessing for it on CT criteria, there is a SARC-F questionnaire which involves a questionnaire of how strong the patient is, do they need any help and assistance in walking, can they arise from a chair, can they climb stairs, or have they had any falls in the last year. And people have assessed a comprehensive geriatric assessment on the post-operative risk of elderly patients having esophageal cancer surgery, and in this study a CGA categorised patients into a robust, a pre-frail and a frail group, and the frail group, as you can imagine, did worse. They had higher rates of pneumonia, leakage, longer post-operative stay, and significantly lower discharge rates to home, and also worsening survival. And they suggested that a CGA could allow focused prehabilitation to those who need it, and the involvement of geriatricians or a perioperative team could help improve outcomes with surgery. Criticisms are that frailty and sarcopenia can also occur in lower age groups, so you can't have a defined age cutoff. And they also suggested that the quality of food and postcode of the patient may have a bigger aspect to play in certain circumstances, and there are papers on places like, they call them food deserts, where quality food in supermarkets aren't available, and patients tend to eat poor quality junk foods. Moving on to how we assess fitness for surgery. Well, you can eyeball them, or you can do something more objective. and the options are either CPEX testing or an incremental shutter walk test. In terms of CPEX testing, the evidence for this is actually very poor. The cohorts are very small, and there's inconsistent association with PET variables and surgical outcomes. In the biggest sort of pooled analysis of 621 patients, the discriminatory ability of CPEX was found to be poor, and the conclusion was it could only really carry an adjunct role in clinical decision making. And the issues with CPET is that whilst its use is widespread, the evidence is lacking. It's also costly, and introduces delays into pathways, and when to perform it is also unclear, as we know that neoadjuvant treatment clearly worsens patient fitness and the results of CPEX parameters. Incremental shutter walk testing is simpler and perhaps more cost effective, as only very basic equipment is required. It can be done in a corridor. Its limitations are it's affected by motivation or lower limb issues such as osteoarthritis or peripheral vascular disease. And the key number for shutter walk testing is 350 meters. There's about 3 papers on this, specifically looking at esophagectomy. And if patients did less than 350 meters, they generally did quite badly, such as had worse survival or higher rates of pneumonia or ICU stay, or if they achieved more than 350 meters, they didn't die within 30 days post-operatively. So what we'd like to do is categorize our patients into a TRAFA-like system. Are they a no-go? Are they completely green? Or are they borderline, and can they be optimized? And the key is, can we get borderline patients over the line? Patient optimization. This is a really good resource which has just been published. The EU PEMN optimization for esophageal surgery, and it has different aspects, including very detailed patient counselling, comprehensive medical assessment, optimization of all chronic medical conditions, but in particularly diabetes, and in particularly correction of anemia and iron deficiency. And it moves on to nutritional assessment, getting your patients to stop smoking and stop drinking, psychological counselling for those that have anxiety or depression, frailty assessments for everybody over the age of 65, and actively dealing with patients who are at risk of post-operative nausea and vomiting, and accurate ASA assessment. And what to do with that information is, well, we have prehab challenges in esophageal cancer surgery. There's only a short period of time to optimize patients. When do you start? Do you start at diagnosis, prior or after chemotherapy? And studies have shown it takes at least three weeks to make any difference. And the patients who are most likely to benefit, elderly, frail, comorbidities, are sadly the most likely to drop out of the programme. What is the best programme? Well, that is completely unclear. This recent meta-analysis of 7 RCTs and 14 observational studies showed that the evidence was actually very poor, and there was lots of potential bias in this research. And whilst the observational studies showed that prehab improved post-operative pneumonia, reduced pulmonary complications and reduced weight loss, there was no real difference in length of stay, length of ICU stay, readmission or post-operative mortality or severe complications. And any of the improvements seen on the observational studies were not observed in the randomized controlled trials. And it's perhaps we're looking at what David Brailsford did for the English cycling team, and we're looking for improved marginal 1% gains. He did this by redesigning bike seats, temperature regulation, lighter fabrics, massage gel, sleeping mattresses, and changing the tour bus. And we might need to look at this in esophageal surgery as well. Doing little things will add up over time. And in summary, patient selection is clearly the queen of the game, but risk prediction is difficult. Frailty and sarcopenia are a real issue, and comprehensive geriatric assessment should be strongly encouraged. Both CPEX and shuttle walk testing have a poor evidence base. Prehabilitation and optimisation of patients are clearly important, but again have a poor evidence base. And 1% marginal gains might be the key to improving outcomes in this evidence-free zone. I'd like to stop there. I'm very proud to be invited to this conference to talk on this topic. I'd be delighted to answer any questions. Thank you very much.